Yes, so this is what I was thinking. That was my thinking to say maybe since I was thinking in terms of some reaction because they take can which they have to give up them and they will build yeah that name. So in time for to at the south, how can we know? We have to go back in retrospective to find out kind of the person. So I think in order to cohort which would to help us to start cases previously, uh, they follow up and find out what kind the person.
Okay. All right. I think,
Hello?
well, yeah, I think, well, the network isn't great and I didn't catch everything
Hello?
you said. But I think that in case where obviously like there's a signal that these people are experiencing this event, obviously, yeah, if you want to conduct like a study, it has to be initially because it's cheaper, and if this information is good, you can, yeah, it's good to conduct. Well, it's not a retrospective cohort, but it would be a case control study because you have your disease already. It's risky sometimes to like, especially with cancers, to continue giving a medicine when there's a reaction that you've seen, because you're still putting people's lives at risk. So sometimes it would be good like to temporarily suspend, or yeah, where anyway, we'll do communication, but generally when like there's a signal, there are warnings like in literature to say this is it, and we'll see that even in this lecture. The first thing that would be important to do would, if it's a serious reaction, it would be good to suspend the drug and also do like a case control, because you don't want to expose people to a drug that you suspect is causing serious adverse drug reactions to the point of death in most people. So you'd want to do a case control study. You already have people with disease. You have people with disease. You have people with no disease. You go back in time. You look for the risk factor. Okay, so if it's people, if it's women who are developing vaginal adenocarcinoma, and you see a lot of them, so you'd now go back in time to figure out what is it about these women who have developed this disease, and what is it about these women who have similar characteristics in everything else except from that disease, that what exposure or non-exposure did they have a long time ago that makes them different now in terms of disease. But they're similar in every other aspect. They're similar, obviously, that if they're female, they'll all be female in that study. There'll have to be a similar age, a similar race, coming from the same environment. Like if they're from Zambia or from Lusaka, then they should all be from Lusaka too, in order to determine that causality. So like with vaginal adenocarcinoma, you'd want to do first a case control study to see, and if you see that actually if the relative risk is really high, you'd actually just withdraw the drug completely, especially if you write to healthcare professionals. Well, especially if that drug is used for only that indication, I think that the thing that should be done would be drug withdrawal and not even keeping it. I don't think that if you went on the market, you'd find diethyl osteobestro right now because of those issues. But thalidomide is the one, remember, that caused women not having children who had no limbs. Okay, children would be born without arms. Okay, so that drug is the reason why there's even pharmacovigilance that we're talking about, together with the osteobestro, and that's why there are clinical trials even up to now. But that drug is used now on the market for other conditions. Remember, conditions like in HIV and so forth. But I don't know, some healthcare professionals still prescribe in women. It's strange. Anyway, the next thing that going to look at now is consistency. Okay, so this is what I was talking about, thalidomide. So somebody noticed, maybe this W.G. McBride, maybe he was a physician. Okay, he noticed that he was prescribing thalidomide to women, okay, as an antiemetic or as a sedative. Okay, so women maybe in their first trimester, you know, they have those morning sickness and so forth. So he's giving these women antiemetics so that they feel better and, you know, they progress well during their pregnancy. So he noticed that, okay, there are these women, all of a sudden, there are these women who are having children born without limbs. What is it that I gave them that caused this reaction? Because previously they were just fine, but somehow after I started prescribing this medicine, they developed this reaction, or their babies developed this reaction. Could it be that this drug is the one that's causing this reaction? So he noticed that himself, and it was difficult for him to excuse me, to determine obviously causality. So what he was looking for is consistency. Consistency is basically seeing this adverse reaction in different people, in different places, okay, maybe in different settings and at different times. So he saw that he was giving this drug to these women and they developed this reaction. So he wrote a letter in the Lancet in 1961 in December. And he said, he described what he saw, that there were congenital abnormalities in approximately 1.5% of the babies that he was given thalidomide. He was given women who were pregnant, he was giving them thalidomide as a sedative and antiemetic. And he noticed that, he said, in recent months, I have observed the incidence of multiple severe abnormalities in babies and delivered to women who were given the drug thalidomide, and the brand name was Distavol, during pregnancy as an antiemetic or sedative, to be almost 20%. He describes the abnormalities, and now he's asking others, have any of your readers seen similar abnormalities in babies delivered of women who have taken this drug during pregnancy? So what he was looking for here, before he could say that the drug is what caused the reaction, maybe it wasn't the drug, maybe it was the environment that he was in, and maybe there's something else in there. Maybe there's an environmental factor that was causing these women to develop that reaction that he was seeing in their babies. So now he was thinking, okay, I am giving this drug to these women. They are different women, it's not the same woman, obviously, so that rules out the genetic issues. So I'm giving this drug to several women, so that's different women, and I've noticed this reaction. So let me ask other physicians, have they seen this? Have they given this drug to women? Obviously, these are different women in a different setting, maybe at a different time as well. Okay, to see, have their babies also developed the same reaction? So this is what consistency is. In causality, for you to attribute causality to or an adverse event to a drug, you must ensure that there's consistency. You've given, well, temporality obviously must be there. Obviously, you must give a drug before a reaction. And then there's consistency. Have I given this drug to these people who are in different places, and have they developed this reaction? So sometimes even cohort studies, and obviously, for, you know, I don't know if you've done the hierarchy of evidence, but you know that a cross-sectional study is above, sorry, a cross-sectional study is below case control, then a case control is below a cohort, and obviously a retrospective cohort is below a prospective cohort. And then obviously that's where you have your systematic reviews and meta-analysis now that we develop causality. Now, for him, what he was looking for is consistency. And in terms of if if other readers had seen this and they also wrote to the journal, and even Uppsala Monitoring Center, obviously there was no Uppsala Monitoring Center at the time, but if there was, if this, let's say the setting is now, you're giving thalidomide here in Lusaka, you've given thalidomide to women in Johannesburg, you've given thalidomide to people in London, to people in Paris, in Australia, in Melbourne, in New York, and you're seeing these reactions. These are different women in different places, in different environmental conditions, and this adverse event is occurring. It would be safe to say that, okay, there could be an association here. And so this is what you're looking for. This is consistency. The drug given to different people in different settings and probably different times as well, to see this reaction. So anyway, I hope consistency is clear. Okay, so this is just an example of some of the drugs in which consistency was established. Is there any question on consistency?
Madam, I want to ask a question.
Okay, go on, McLaurin.
Sorry, I had not put up my hand, but
It's okay.
with regards to, okay, thank you so much. With regards to the observations that were done on thalidomide incident, were they occurring for those particular pregnancies for which thalidomide was prescribed for, or it was later on after maybe there's delivery for that pregnancy, but now in the long run? So how were the incidences occurring?
Okay, what was happening is these women were given like thalidomide, like in the first trimester, there's like morning sickness and stuff. So they were given thalidomide, okay, as an antiemetic. Those children, immediately they are born without arms. You can see that this baby has no arms. They have no limbs. Then you deliver another baby. Maybe in a day, you have 5 babies being delivered without arms. And you start to wonder, what is it? All of a sudden, we're having babies that are being delivered without arms, without limbs. So it was not noticed in utero, but after delivery. And so this is where they started suspecting, to say, okay, there are some babies that are normal, they're okay, but there are others who are born without arms. So what could it be? It's not like the baby's arms fell off, but they were born without the limbs. And this is because thalidomide affected the development of their arms. So yeah, it was seen right after birth, and so that's how come this physician wrote in the Lancet. And Lancet is a big journal, so it was written there to try to establish whether people in other places had seen the same thing happening.
Okay. Well,
Yeah.
thank you so much. Thank you so much.
Okay. All right. So the next one is about biological plausibility or plausibility. As you've noticed, you guys, what I'm saying is not exactly in the notes. You can see they're mostly just illustrations. So I hope that this is making sense for you and that you're taking some notes here and there. But at the end of the lecture, obviously, there are links that have been given where you can actually read what this is about. Plausibility. Plausibility is simple. Is there a biological mechanism by which a drug can cause a reaction? Okay, is there a biological mechanism by which a drug can cause a reaction? Let's say let's say NSAIDs. I don't know if this is familiar for you. I okay, I don't know what you know and what you don't. I know that the pharmacology is hard, like in terms of maybe grasping the mechanisms, or remembering mechanisms, remembering the drugs which belong to which class, remembering the adverse effects and all of that. I know it's hard, but it's something that you have to do, and it's difficult for me to know what you know and what you don't. And obviously, because there's so many, some of you know one concept and some of you will not. So let me try to I don't know. Okay, let me use coagulation. I know I taught you coagulation, so I don't know if I think I gave this example even last time. Somebody will take vitamin K in their diet, fatty foods. Okay, vitamin K is fat soluble. So they take vitamin K in their diets, and this needs to be activated. Okay, vitamin K needs to be activated so that it can in turn be used to activate or to carboxylate factors 2, factor 7, factor 9, and factor 10. So I want to draw these again because obviously that would take too long, but these will need to be activated, and they'll be activated or they'll be carboxylated, sorry. So you take in vitamin K in your diet, in fat soluble food, it's not activated, but when you take it in, your liver will activate vitamin K using vitamin K epoxide reductase. So your liver will activate the vitamin K that's been obtained from your diet using vitamin K epoxide reductase. Once that vitamin K is activated, it can be used to carboxylate. Sorry, in fact, instead of putting active there, I'll put carboxyl group. So vitamin K, which is active, can be used to carboxylate factors 2, 7, 9, and 10. Factors 2, 7, and 9, and 10 will then participate in the intrinsic and extrinsic pathway of the coagulation cascade, right? And then obviously that will promote clotting. Now, if this person has a DVT, somebody has a deep vein thrombosis, and somebody is given warfarin. Okay, a deep vein thrombosis, if you remember, somebody who tends to, they have this lump in their left leg, and they have a coagulopathy. They tend to, their blood can tend to form clots. And what you want to do is maybe give them warfarin. Warfarin will inhibit vitamin K epoxide reductase. And when it does that, it means that factors 2, 7, 9, and 10 will not be carboxylated, and therefore they cannot participate in the intrinsic and extrinsic pathway of the coagulation cascade, meaning that somebody's blood will not tend to form those clots. Okay, so that's that. Now, there are some people, if you overdose with warfarin, this person can bleed. Okay, so they tend to bleed out. They can have internal bleeding because their blood is too fluid, so it will pass through those, intracellular spaces. Sorry, intercellular spaces. Okay, they start to bleed out, and and that's obviously dangerous. So that is what we call plausibility. If you have given warfarin to this person and they present with internal bleeding, that is an adverse event. Okay, warfarin, you've given them and they present with internal bleeding, that is an adverse event. How did that adverse event occur? You try to think about it and you're like, you know what? There are others I'm giving warfarin to. They do not have internal bleeding, but there are others I'm giving warfarin to and they have internal bleeding. What is it about warfarin? I gave someone 2 milligrams of warfarin and they were fine. I gave somebody else 5 milligrams of warfarin and they're presenting with internal bleeding. What is it that I'm doing? Okay, what you're doing is that you're giving a high dose of warfarin to this person. Of course, if 5 milligrams is okay for some individuals. There's some who take 1, some who take 2, some who take 5, some who take 10, and so forth. But you're giving an overdose to this individual. They've developed an adverse event of internal bleeding. The biological mechanism, you can think about it. I've given too much. The vitamin K epoxide reductase has been inhibited, and so the vitamin K is no longer able to carboxylate factors 2, 7, 9, and 10. And so even if somebody, generally, even in our bodies, we tend to injure ourselves. Sometimes you bruise yourself. Okay, you might not see an injury on your skin, but your vessels inside have been bruised. And so it's up to your body now to cover those micro punctures throughout your cardiovascular system. All of us, even up now, even though you do not have a DVT or coagulopathy, you have micropunctures throughout your cardiovascular system. And it's up to now your coagulation factors to make sure that they form clots at those places, the platelets function well, and so forth. So now, in this case, you can say, okay, the biological plausibility is there. I've given too much warfarin. It's inhibited these factors extremely. Okay, too many factors, 2, 7, and 9, and 10 have been inhibited such that this person can no longer clot healthily, even to the point that even micro punctures are not being sealed. And this person is now presenting with internal bleeding. That is what we call biological plausibility. There is a mechanism by which you can explain an adverse event that a patient is experiencing. Okay, now, as you know, there are with knowledge, you develop more knowledge over time. Okay, there's you remember from third year pharmacology that there were some drugs in which you do not know the mechanism in which they are even efficacious, or you do not know these mechanisms. So how would you even know the mechanism by which a drug is causing an adverse event if you don't even know the mechanism by which a drug is treating a condition? But all you know is that it works, but you don't know how it works. Okay, like there's some anti-TB drug. Is it a pyrazinamide? Or is it the Thambito? I don't really remember clearly, but one of them, we don't know their mechanism, but we know that it works. Okay, so how do you know a mechanism by which this drug is causing an adverse event? You don't. So sometimes with biological plausibility, this is not really a necessity for you to say that this drug has caused this adverse reaction and I can explain it. Because, you know, with knowledge, we develop knowledge over time as we come up with different mechanisms of elucidating structures. Like maybe before we didn't know that NSAIDs could cause peptic ulcers because they inhibit cyclooxygenase 1 and inhibit prostaglandin production in the stomach mucosa. So yeah, with biological plausibility, you don't always expect that to be there right there and then, because we don't know everything there is to know about mechanisms of actions. So anyway, but sometimes you do. And this is to say, I think with biological plausibility, the adverse events are the ones that immediately a drug is released, you would see those adverse events or adverse drug reactions on the patient information leaflet, because they already knew about these reactions even when they were developing a drug. They saw that, okay, when we're doing a clinical trial, when we're doing a lab test on a lab bench, the exploratory stage or the drug discovery stage, we saw that these are the reactions that were possible. In the preclinical stage, when we tested the animals, these are the reactions that were presented. When we went to clinical trials in humans, these are the reactions that occurred. And these, remember, these are type A reactions related to the mechanism. So you know that, okay, these are the adverse drug reactions, and that's a biological plausibility. So, but of course, this is not always the case, especially if we don't know the mechanism by which a reaction can occur. All right, I've dwelt so much on this. I hope biological plausibility is clear for all of us. We need to move on quickly until we get to analogy. Is there anyone who has a question? Okay, no. Specificity is, as the term tells you, is this reaction specific? Okay, am I giving, I'm giving aspirin. Okay, I'm giving aspirin and somebody is yeah, okay, aspirin, no aspirin. I'm giving, disease, no disease. Okay, aspirin, how many people have I given aspirin to who have developed a disease? I've given aspirin to 1,000 people, but 700 of them have developed peptic ulcer disease and 300 haven't. I'm giving other people meloxicam. I'm giving them meloxicam. It's also a cyclooxygenase inhibitor, remember, but it inhibits COX-2, so it's less likely to inhibit prostaglandin production in the stomach mucosa and less likely to cause peptic ulcer disease. So specificity is this reaction specific for this drug? Is it that, okay, I'm giving a person, I'm giving them antipsychotics, right? And at the same time, okay, let me ask you this question. What are the most common adverse drug reactions that you guys know of that you would resort to if you're told, give me an adverse drug reaction for this drug? What's the most common one that you would resort to? I know you know this. Anyone to tell me? Anyone to tell me the most common adverse drug reactions that occur with any drug?
Madam, there is a poor sexual libido in most antipsychotics.
Okay, but like, I mean, like every drug, any drug, every class of drug, anything. Isn't it that you guys mostly, when you're asked about the adverse drug reaction, you go to nausea, vomiting, NVD, nausea, vomiting, diarrhea, isn't it? So if I'm giving aspirin, okay, and I'm giving warfarin, or I'm giving an antipsychotic to this person, okay, I'm giving 3 drugs. I can't say that nausea, vomiting, diarrhea are only caused by warfarin or are only caused by aspirin or antipsychotics, because this NVD is a general adverse drug reaction for almost every class. Not everybody experiences this adverse drug reaction, but you'd expect, I think most of the drugs you've seen, even if you remove your BNF, you'll see nausea, vomiting, diarrhea for almost any. So with specificity now, we're saying that I've given aspirin to this person, and I've also given, okay, no aspirin, or I've given meloxicam, or I've given warfarin. The people who have given aspirin to, 700 of them have developed peptic ulcer disease, and then 300 have not. Okay, and then I've given, but then, yeah, okay, actually I was supposed to draw this the other way around. Anyway, I've given aspirin, 700 people have developed the peptic ulcer disease, and 300 have not. And then I've given maybe warfarin to people, and then to 1,000 people, and then only 100 have developed peptic ulcer bleeding, but 900 have not. So specificity here, you could also say it's related to relative risk or odds ratio. So this drug has to cause a reaction which is specific for that drug, and not something that you'd expect to see even on a normal day. Sometimes, like even pregnant women, they experience like nausea, vomiting. Would you say that maybe folic acid is the one that's causing the nausea, vomiting, diarrhea? Meanwhile, you're giving folic acid in the first trimester in order, as a supplement, or ferrous sulfate. Would you say that folic acid and ferrous sulfate are the ones causing nausea, vomiting, diarrhea? Not necessarily, because pregnant women will experience nausea or vomiting because they're in the first trimester, or those are symptoms of a morning sickness. So with specificity, you would expect that this drug has caused this reaction, which is truly specific and truly unique. So yeah, that's that. I'm pretty sure it's clear. So an example of specific reactions are chloroquine induced maculopathy, where somebody's vision starts to be affected due to long-term administration of chloroquine, which is why these drugs, I'm sure you've heard of the hesitancy, especially with treating COVID-19. Well, I think the main concern generally with hydroxychloroquine or chloroquine is that there's maculopathy, but there's generally QT prolongation, especially when you give with azithromycin. So I think that's why there's hesitancy. We already know this, so I don't even know why people are going back to chloroquine and hydroxychloroquine and even azithromycin. We know that there's QT prolongation, so you can't really use it for COVID-19. I don't know why the discussion is being had. Then there's also Nicolau syndrome and also amiodarone and induced discoloration. So this person or a group of people are given amiodarone, and they notice that, okay, other people don't discolor. Their skin doesn't get discolored like this one. But look at these people that were giving amiodarone to, and look what's happening to their skin. Okay, they're getting discolored. And so you'd say that this is caused by amiodarone. Those are other examples of specificity. I'd like to move on to biological gradient in the last 5 minutes of this session. And then in the next, when you join back in after a cutoff, we'll look at the last 3. Biological gradient is easy, okay? Dose response, okay? It's dose response. Hypersusceptibility, remember I looked at that curve. Collateral adverse drug reactions and toxic reactions. Biological gradient, remember with morphine last time, that those people who are hypersusceptible, such that if you give a low dose, of course this is the response, this is the dose. Okay, so you give this curve is for hypersusceptible people. You give them a low dose and they experience an adverse drug reaction, and you're like, well, I haven't even given you the therapeutic dose, and this is the response that you're getting. Okay, obviously you'd expect that with like drugs like penicillins, where some people experience allergic reactions. Then there's a therapeutic one. The higher dose they give, the greater the therapeutic response that you give. But then, like especially with morphine, you know, this therapeutic window. Now with morphine, you give a drug. The higher the dose that you give, the more the respiratory depression that person will experience, especially when they're on the toxic dose curve. Okay, this is the toxic dose curve. The higher the dose you give on this curve, the greater is their respiratory depression. So we know that when I give a drug in this region here, I'll get a therapeutic effect. Okay, I'll give a dose and I'll get pain relief or an analgesic effect. I give a higher dose of morphine, I'll get a higher degree of pain relief. A higher dose of morphine, a higher grade until you reach the peak. But when you bypass this peak, now you've gone on into the toxic dose curve. The higher the dose you give now, the greater the amount of respiratory depression you give. If you give a dose here, there will be respiratory depression. But if you give a dose here, the respiratory depression that patient will experience will be much higher than the respiratory depression they experience there. So that's biological gradient as well. I'm giving a person 5 milligrams of warfarin, okay? And I'm giving somebody 10 milligrams of warfarin, okay? So this person I'm giving 10 milligrams of warfarin is going to experience a higher degree of internal bleeding than a person who's been given a 5 milligram dose of warfarin, obviously because of the dose response curve here, and they've gone into toxicity. Of course, some people take 10 milligrams, 5 milligrams, 7 milligrams, 1 milligrams, 3 milligrams of morphine. Just depends on what the physician has seen. But this is it with biological gradient. You'd expect that, you'd expect that the higher the dose you give, the more the adverse reaction, or the greater the degree of the adverse reaction that you'd be seeing in that patient. So I hope that's clear. Maybe I can do coherence so that in the last time you join, you just look at experiment. Okay, let me just go on. Anyway, this is what I was explaining. Coherence. Okay, coherence just means that you've seen an adverse reaction. Okay, you've seen an adverse event that the person has experienced. Now, that adverse event, you don't want to say that it contradicts what you already know. Okay, you all of a sudden you're saying warfarin does not cause internal bleeding, but instead that it causes coagulation. Meanwhile, you know that's not the case. Whatever mechanism that you're saying causes an adverse reaction should not contradict the current facts about science that you know. Okay, you're not going to say that aspirin doesn't cause peptic ulcer disease. Meanwhile, we already know the mechanism that aspirin causes peptic ulcer disease because it inhibits COX-1 in the stomach. We're not going to say that antipsychotics do not cause hypotension, blurred vision, dry mouth. Meanwhile, you know that they inhibit muscarinic receptors and that they inhibit H1 receptor, alpha-1 receptors and H1 receptors by causing sedation. So yeah, that's that with coherence. Whatever you're saying should not contradict current facts about science. So join back in, then we look at the last two. The session's about to cut out. We'll only take 10 minutes and we'll be done with the lecture. Is somewhere implicated in there. You can't be 100% because, like I said, you don't have all the mechanisms by which you'd know that the drug is causing an adverse drug reaction. Sometimes you don't really know if a drug is being converted into an active metabolite in the body. Okay, so there's all these gaps in knowledge that are yet to be filled. So in applying, trying to determine causality between a drug administration and an adverse event, you're not always going to be very strict, but what you do require is plausibility. Sorry, what you do require is order in time, which is temporality. You want to make sure that you gave the drug before that person experienced the adverse event. And then obviously from there, Uppsala Monitoring Center will go on and make sure that at least most of these are in place before testing can be done to see. So obviously, when it comes to like drug A being converted into drug B, how to test this, you can even go back into the lab and do experiments to see what exactly happens to this drug when it enters the body. Remember the pharmacokinetics that we looked at when we're doing clinical trials and so forth. So there are all those issues that can be modeling in that case to see what happens. You know about radioiodine, you can see what's happening to the iodine after somebody's taking it into the body. So these are the Bradford Hill criteria that can be used to determine whether an adverse event is caused by drug administration. With clinical practice, obviously, you may not be required to determine this before you report an adverse drug reaction. You will not have to calculate the relative risk. You will be required to say that the drug was given before the adverse drug reaction. You will not be required to determine consistency, but you can see consistency by looking at dear editor letters there. I don't know if we do write those. I don't know if Mr. Mdenda has shown you some dear editor letters, but anyway, the dear editor letters can help you get an idea of what other physicians are seeing or other people are seeing in other regions. It's not just physicians, but other healthcare professionals. Just like we saw that Dr. McBride wrote that letter in the Lancet to ask if other physicians had seen abnormalities due to thalidomide administration. So you can kind of try to get some idea of some consistency of drug administration with an adverse event. You never know 100% with biological plausibility because you would have to know the exact mechanism. Specificity does have to kind of be there. You've seen that you've given penicillin and somebody's experienced the Stevens-Johnson syndrome. People don't go about just waking up and experiencing Stevens-Johnson syndrome anyhow. It usually comes after administration of a drug. Biological gradients, if you've given somebody an overdose, you'd expect that they would experience an adverse drug reaction. With coherence, you're not going to say that I've given warfarin and all of a sudden this person is clotting due to administration of warfarin. That doesn't occur. So the adverse drug reaction must be kind of consistent to what is already scientifically proven. You're not going to do experiments on humans. You're not doing, you will have to have approval to do clinical trials. You can do testing in the lab, obviously after ethical approval. So yeah, but in clinical practice, you will not experiment on humans unless you have approval. Analogy, you don't know all the information that's necessary. Well, you don't know the biological mechanisms or the plausibility, so you must be willing to think of a way or a mechanism by which a drug can cause an adverse event. So these are the criteria, the Bradford Hill criteria. Like I said, I hope you took down notes. So yeah, an example of analogy is right here. Mercaptopurine has been registered since August 1967. It is indicated for the treatment of acute lymphatic leukemia and so forth. And the mechanism of action of mercaptopurine is based on its cytotoxic antimetabolite activity. The drug is an inactive prodrug, which acts as a purine antagonist. Okay, so it's a purine antagonist, but it requires cellular uptake and intracellular anabolism to thioguanine nucleotides for cytotoxicity. So the mercaptopurine metabolites inhibits the de novo purine synthesis. Remember, we looked at this when you guys were in second year. We looked at de novo purine synthesis. So in the first quarter of 2008, LAREB, which is this Pharmacovigilance Center that prepared this notes, LAREB wrote a quarterly report on the photosensitivity reactions in patients experiencing azathioprine. See, we're not talking about mercaptopurine, but we're talking about azathioprine now. But these are different drugs. Okay, people are given azathioprine, but they're experiencing photosensitivity reactions, but these photosensitivity reactions are generally seen with mercaptopurine. So what's going on here? The reason is that photosynthesis reactions could be related to this of the drug because mercaptopurine is the active metabolite of azathioprine. So these people who took azathioprine, the azathioprine was converted into mercaptopurine in the body, and mercaptopurine causes photosensitivity reactions. So this is just an observation, and this is an example of analogy. Okay, so yeah. Anyway, this is it. These are the Bradford Hill criteria that we've looked at today. So none of these 9 viewpoints, however, can bring indisputable evidence for against the cause and effect hypothesis. So just because an adverse drug reaction has filled all the criteria, or the 9 Bradford Hill criteria, you can say that the drug caused an adverse event. No, you can't do that. There are actually other mechanisms that well, they're used like Bayesian models and so forth that can be used to determine. And obviously, even after that's to determine a signal, and that signal is like, okay, there are so many adverse drug reaction reports or adverse events reports coming from different countries, in different places, and different people, in different environmental settings. And the system, the database, you've seen that there's a signal that warfarin has a tendency to cause bleeding even at a low dose. So what are we going to do? We're going to now, to prove this, it's not just that we're using the Bradford Hill criteria. Now we're going to start doing case control studies. Now, after doing a case control studies, we can even go into cohort studies. When we see that the relative risk is now super high, then we're like, okay, I think here there's definitely something, because we have evidence from adverse drug reaction reports, we have evidence from a case control study, a cohort study, several cohort studies are conducted. You now do a meta-analysis, and then that's the highest level of evidence there is. At that point now, the pharmaceutical company can have no choice but to withdraw the drug permanently from the market, or they can update the labeling information, the patient information leaflet that you see. They can update the prescribing information. They can adjust the dose in children, in adults, in whatever the case is. Something has to be done by the manufacturing company to make sure that the benefits of that drug outweigh the risks in giving that drug. Because remember, at the end of the day, benefits must exceed the risks in terms of adverse drug reactions. Okay, so I don't know who's drawing those things, because it's not me, but one of you guys is drawing things on the slide. So anyway, causation may be difficult to prove in practice, and the counterfactual theory can help to understand causality, and the Bradford Hill criteria can play a good role in the assessment of a causal relationship between a drug and an adverse event. So yeah, those are exam questions, but those are too simple for me to bring for you. Obviously, I would like to bring a case study. I told you guys the methods of assessing you this time is very different. I'm not just going to bring, oh, can you describe temporality for me, or can you describe strength of association? That's too simple for you. We're going into different methods. Understand the concepts. I bring a case study for you. You tell me which Bradford Hill criteria can apply in that case study that I would bring. Yeah, I was actually thinking in terms of your test, I think it would be like, I'll bring a case study and then I would ask you like, it would be like maybe an MCQ or matching question. I don't know. I'm trying to figure out, but I don't want to bring essays. I'll try to figure out a way in which I can bring MCQs and matching questions, but in the form of case studies, so that you guys can see your results immediately you're done with your test. And I won't have to mark, obviously, because there are so many. So yeah, that's that. Are there any questions before we end this lecture? I hope this has been clear for you. The notes, I'll put the link again. These notes are not mine. They're prepared by the WHO in collaboration with the Netherlands LARB Pharmacovigilance Center. And so I'll just put the link. There are multiple notes or presentations there, but like when you go into Moodle, you will see that I've specified the notes that you should get from the Uppsala Monitoring Center for the case of studying. So yeah, I'll put the link maybe just right now. I'll put the link so that you guys can go on and start reading. Next week we have my last lecture with you. We'll be looking at Zambia in particular. Maybe I'll try to pull out an adverse drug reaction report so you can see what it looks like. Maybe we'll see how to fill it in and the methods that we can use to report an adverse drug reaction here in Zambia. So it will be short, I think. Yeah. So anyway, that's that for today. If you have no questions, no comments, no contributions, anyone before I end the session? Okay, anyway, you guys have a good day. Bye.
Thank you, madam.
Thank you, madam.
Bye.